Welcome everybody for joining today's webinar, which is the second webinar on the topic of rehabilitation. My name is Ewout van Ginneken. I'm the director of the European Observatory on Health Systems and Policies. And I am moderating this webinar together with my colleagues Stephanie Vanitsky, who will be doing the chat box together with Erica Richardson. Today's webinar is the second webinar. 3 weeks ago, we discussed the delivery of rehabilitation care. And already then we got many questions on how these services are actually financed. And people rightly saw this as a huge obstacle to better provision of such services. The work that we will be talking about today builds on the work that we have done together with our WHO colleagues in the form of a policy brief and the link you will get on rehabilitation care. There will also be translation available for our Ukrainian audience. This brief was done specifically also for Ukraine, to support Ukraine in these difficult times, but it's also written so that it's accessible for a European audience. So rehabilitation services are essential. They help patients with the loss of function and independence and are increasingly important as populations age and in the face of conflict-related injuries. However, these services are very fragmented over different systems, and therefore it really makes sense now to focus on how the financing is organized. And therefore, we will look at what are the financing policy options, how can coverage prioritize populations and services, and how can payment mechanisms enhance performance. Before we move to the program, I'm also very happy to hear from my WHO colleagues who joined us here today. And the first one is Natasha Azzopardi-Muscat, the Director of the Division of Country Health Policies and Systems at WHO Regional Office Europe. Natasha, the floor is yours.
Good morning, good afternoon, Ewout and colleagues, and thank you for inviting me to say a few words with you. I think this has really been a great joint venture. Also, when we were together in Kyiv, I think that was really around a year ago. And rehabilitation is an urgent issue facing every country in our region. We know demand is rising sharply, driven by aging populations, chronic conditions, injuries. But when it comes to Ukraine, unfortunately, also the impact of conflict. And this is precisely why we were delighted to develop this report together with you to help countries learn from each other, learn lessons from the experience in Ukraine, and strengthen the way in which rehabilitation services are organized and financed. And the report itself, of course, examines how rehabilitation is delivered and funded across several countries by tracing real patient pathways, following people after stroke, back pain, or limb loss, and looking at how services link across hospitals, primary care, community, and home, and how these services are paid for. And a central insight, I think, strikes me, which is that while rehabilitation is often guaranteed on paper, in practice, systems everywhere, even in high-income countries, frequently fall short. Services are fragmented, people wait too long, or receive it in hospitals with limited support beyond discharge, with community-based rehabilitation and coordinated transition pathways remaining rare and negatively affecting the long-term outcomes. At the same time, on a positive note, we see that countries are investing in care coordination, using case managers, early support discharge teams, shared data systems, and when they do so, they achieve far better continuity of care and improved results for patients, which is what truly matters at the end. We see that countries differ in the way they are financing rehabilitation, and that this is sometimes shaped by historical contexts, but also by the different policy priorities at hand. And I think one take-home message stands out. Investing in rehabilitation is not a luxury, should not be an afterthought in budget. It's actually a smart pro-equity investment that strengthens both health and social systems and benefits economies and society as a whole. And today, of course, you will hear in greater depth about the experience of Ukraine, including findings from the dedicated report on the country's rehabilitation financing under the immense pressures of war. Needs have grown significantly, and my colleagues will be exploring what more is required to invest so that everyone who needs care, even in these really difficult circumstances, receives it. And I close by saying that WHO Euro remains steadfast in our commitment to supporting Ukraine in advancing its rehabilitation policy objectives, but of course, through the efforts of Jarno and his team on the ground more widely. And I hope that today's discussion will inspire concrete policy action. And I'm afraid that I'm going to have to jump off because I have to replace Hans. We have a high-level event here looking at age-friendly communities working with municipalities and regions in the Nordic and Baltic countries. And of course, I think that rehabilitation will also be central to the discourse at this event taking place in the UN city. So thank you very much, Ewald, for giving me the opportunity to say a couple of words, and back to you and Erika.
Well, thank you very much, Natasha, for those words. And now let's go to Jarno Habicht, who is a WHO representative and also the head of the WHO country office for Ukraine. Jarno.
Thank you, Ewald, and good to talk after Natasha. And thanks also for all the support. I think it has been a great partnership, and it will continue as a WHO and observatory. And since 22 February and the Russian Federation invasion, rehabilitation needs growing. But I want to say that rehabilitation is very much needed also after the stroke, after injuries, which are not war-related. So that's why I think it's relevant for many. But at the same time, what we have learned at the wartime, there are much more amputations which are needed and much more injuries which need also the rehabilitation. So what has happened in Ukraine is the providers have increased their capacity. Much more healthcare workers have been trained, and I will not start to name all the specialties you need to work on spinal cord injury or after any other injury. But also we have seen that the financing has increased at least twice, and colleagues will tell more during the last few years. So in that environment where you have immense needs, you have to train many of professionals, you increase the financing, but you want to be efficient to respond to those needs. We as WHO team, together with the Minister of Health and colleagues in Ukraine, have been looking what we can learn also from others. Because of course we are responding, but there is always possibility to learn. And I think from my experience over the decades, the place to go is European Observatory. So thank you for the partnerships on putting together cases from 14 countries. We hear a little bit more, and we have learned already a lot of from this partnership, what to do more in Ukraine in the coming years. But I think it's really a webinar also for others to think what we can learn more, because what Natasha was mentioning also, we need rehabilitation on the time of war and peace. We need the rehabilitation at the time of aging population. And ultimately, all of us want to live our life in full functionality as well. So it is something that we need to explore more. So thank you for the opportunity. Thank you for the partnership. Thank you for opportunity for sharing, thinking together as we go through these difficult times. Back to you, Ewald.
Thank you very much, Jarno, and also for the very kind words. It's really a privilege for us also to work with WHO and support Ukraine in these difficult, very difficult circumstances. Before we go to country spotlights on Italy, Sweden, Ukraine, and also in WHO perspective, we first will have an overview from my colleague Ruth Weitzberg, who works in the Berlin hub of the European Observatory at the Berlin University of Technology. Ruth, over to you.
Thank you, Ewald, and thank you, Natasha and Jarno, for opening this session, because you set the scene very well for the presentation. I will present the report that you mentioned, Jarno, that is the collaboration between the Observatory and WHO Ukraine. I am putting my presentation on presentation mode. And today we will learn how countries can improve financing rehabilitation, because we know that, as Natasha mentioned, the need is only growing, but their budgets are constrained and we cannot always add money to the system. So we asked 14 different countries how they are improving value for money, how they are using the money they have to better improve value. And value can be increasing quality of care, coordination of care, reducing waste, reducing unnecessary costs, allocating the money where patients can receive more value and more better care, and how to prioritize the coverage that patients receive. This is a snapshot of the report, and it's available at our website. And here is a map with the 14 countries that helped us collect the data for today's presentation. So the first set of policies related to financing, better financing rehabilitation care, is related to coverage and eligibility policies, because we have to prioritize what we cover and to who. So here I will present some challenges faced by several countries and strategies found to overcome these challenges. So first, we know that we cannot cover all the services for everybody, every time and everywhere, and we have to prioritize. And the way countries can do that is to have different layers of coverage depending on the need of the patients. So it is very important to focus on the vulnerable groups that face access barriers or fragmented coverage, and they suffer twice. First, because they have to pay more because they have higher needs, they utilize more the services, and also they miss more working days, so they have reduced income. So how can we reduce financial hardship? How can we direct the funds that we have available to those most in need? So first of all, it's good to have rehabilitation in the basic benefits package and have at least some kind of rehabilitation care for everybody, because everybody might need that care. Then we can have broader coverage for vulnerable groups, meaning groups that have higher needs or have lower capacity to pay. And this could be, for example, reduced copayments or exemptions from copayment or extended benefits. And typically, countries have broader coverage for children, people with disabilities, people with low income, pregnant people, patients with dementia, or, for example, also refugees in Poland and Turkey. A second set of strategy is having a second layer or a third layer of coverage and extended specific coverage for populations with very complex needs. But then it's important to have standardized clinical criteria to determine the eligibility and allocate this extra coverage to the patients that really need it. So, for example, typically these are stroke patients or patients with limb amputated or with development impairment, patients with brain injury, older patients with disability, and victims of conflict and terror in some countries. The fourth layer of coverage actually comes from outside the health system, and parallel system can come in and cover rehabilitation services for specific population groups, for example, military coverage for veterans of war, or social care for disabled people, or long-term care schemes for frail older adults. It is important, though, to coordinate all these coverage systems to avoid duplication of care or service gaps, because this creates inefficiencies. Another important way of reducing waste is reducing supplier-induced demand or overuse of inpatient care when it's not necessary because it's more costly, and we should aim to shift care to the outpatient care, mainly to primary care and community care. How countries can do that? First, they can set eligibility criteria that determine the treatment needs and the treatment pathways. And this can be done, for example, with the Bartle Index. And countries can either do that at the national level to standardize this decision-making and have less variation, or they can give the decision-making to the treating professionals to tailor these service paths to the needs of each patient and patient. Another strategy is limiting utilization of care by predefining episodes of care where there is a number of hospitalizations or number of encounters with the rehabilitation professionals that people can have. And after this episode of care and this package of services is fulfilled, the patient is reassessed, so the needs are reassessed, and another episode of care or package of treatment is given to the patient. And this way we limit or we tailor the treatment according to the needs of the patient and the progress of the rehabilitation care. Other countries caps the service from the provider side. This has to be done with caution, not to underprovide or limit too much the treatment and still allow for provision of the treatment in need. The next group of policies that we learned that can help reducing waste and improving quality of care relates to purchasing and paying providers. So here we have a figure that helps us understanding the payment characteristics and how they create economic incentives and change behavior of providers. We have in the right hand of the slide payments that are retrospective, they are narrow, they are linked to activity, and put the financial risks on the payer level. These payments create incentives for increasing productivity, which is good in itself, but if it's exaggerated, it can create over-provision and waste. On the left side of the spectrum, we have payments that are prospective, they're very broad, they are fixed, so no linked to activity, and they put the financial risk at the provider side. These payments, they create incentives for cost containment, which is also good in itself, but if exaggerated again, they can lead to negative selection of patients or under provision of care or dumping quality. And the whole idea is to balance these incentives and utilize payments that either complement each other or are in the middle of the spectrum. And countries are doing that actually to pay for the different services in the different settings of care. So for example, in inpatient care, we see a cluster of countries paying global budget because that limits provision and avoids overutilization. Another cluster of countries pay with per diem, and they adjust per diem rates to the patient characteristics or the length of the hospitalization. And other countries use DRGs that also balance more the incentives and avoid over-provision. For daycare, countries can pay either global budgets or per diems, but also some countries pay fee-for-service to promote increased activity because they want to promote daycare instead of inpatient care, for example. Finally, for outpatient care or primary care or community care, there are still some countries that pay global budgets and some countries pay capitations, but we see a big group of countries paying fee-for-service. And this is because they want to incentivize productivity and treatment of patients in the outpatient care, particularly in primary care. Some countries apply caps to limit the provision of services in the community care because we don't want to exaggerate either. So these are tools used by the different countries. I want just to finalize saying that it is important to pay for activities that are not purely clinical, for example, care coordination or incentivizing quality of care, because the payments that we saw so far, they incentivize productivity or cost containment, but newer and more innovative payments can incentivize improving care coordination, quality of care, and patient-centeredness. So, for example, England and other countries have bundled payments for stroke that encourage integration of hospital care with outpatient care. So, for example, the hospital receives the bundle payment and they are in charge of subcontracting rehabilitation professionals out in the community care, and they foresee the whole path of the patient in the treatment. We have pay for performance, we have pay for coordination, and we have dedicated payments for professionals' home care and travel costs. I will stop here. I want to thank our colleagues from the 14 countries that helped us collect data for this study, and thank you for your attention. Back to you, Ewout.
Thank you very much, Ruth, for this very comprehensive presentation. I think we now all get a good idea how complex the situation is, how fragmented it is, and what a huge variety we see. So let's now dive into the countries, and we're going to Melissa D'Agostino. She is from the University Cattolica di Roma in Italy, and you will be talking about contracting with public and private rehabilitation services.
Good morning. Very happy to share with you the Italy experience. In Italy, rehabilitation services are organized through a mixed model that brings together public facilities and accredited private providers. On one side, we have public hospital rehabilitation centers within the National Health Service and community-based services. On the other, there is a network of private facilities that are formally integrated into the public system through regional accreditation and reimbursement mechanism. This coexistence between public and private accredited providers serves several important purposes because it first increases the overall availability of services. The public system alone, especially in certain regions, would not be able to guarantee enough beds, outpatient services, or specialized rehabilitation programs to meet the need of the population. So in this sense, private providers help expand capacity and reduce waiting lists, ensuring that patients can start rehabilitation in a timely manner. Second, accredited private facilities often help compensate for territorial gaps. Not all regions have the same organizational capacity or the same availability of professionals. For example, rural areas often rely on these private centers to ensure that rehabilitation remain accessible close to patients' homes. Another key contribution is specialization. Many private providers have developed advanced expertise in areas such as neurological, orthopedic, or cardiac rehabilitation. So they often introduce innovative technologies and more up-to-date therapeutic approaches, bringing added value and dynamism to the entire national system. However, this mixed model also presents several challenges. One of the most significant issues is regional disparities. The distribution of accredited facilities vary considerably across Italy because some regions have extensive networks while others have far fewer resources. So this leads to unequal access and differences in continuity of care depending on where a person lives. A second challenge relates to contractual inconsistency. Each region set its own rules, tariffs, and quality requirements. As a result, patient may receive services at different quality or with different costs simply by moving from one region to another. Likewise, professionals working on different parts of the country may face different standards and expectations. Another critical issues could be the fragmentation of care pathways because the transition from acute hospital care to intensive or extensive rehabilitation to finally to community services is not always well coordinated. So without a clear organizational clinical pathway, patients may experience interruptions in their care or may have to navigate the system on their own, and which all can compromise outcomes. So I can highlight here two key strategies to address these challenges. The first is to standardize contracts between public and private providers to ensure similar level of care everywhere, and to link contracts to quality and outcomes rather than focusing only on the volume of services delivered. So instead of paying only for the number of treatments of admissions, regions could also evaluate indicators such as functional improvement, patient satisfaction, or reduced long-term disability. Just to conclude that the coexistence of this mixed model is, of course, one of the strengths of the Italian rehabilitation system, because increases capacity, promotes innovation, and makes services more accessible. However, to fully harness its potential, Italy needs better coordination and a more robust focus on outcome. Thank you very much.
Thank you very much, Melissa. And I think that is definitely an issue that many countries are probably dealing with, how to work with the private delivery of services and how to regulate it in such a way that it also meets societal goals. Okay, so now we're going from Italy to Sweden, and we're going to hear from Erik Svanveld, and he will talk about the Act on Collaboration and Discharge from Inpatient Care. So also on what the impact was on the financing for rehabilitation care. So Erik, over to you.
Thank you very much. So I will talk about the Swedish Act on Collaboration in Discharge from Inpatient Care, and which has had big impact on where rehabilitation takes place and who is financing it. The Swedish healthcare system is decentralized. It's mainly tax-funded, and it covers all residents. The regions, they have the main responsibility for health and medical care, and the municipalities, they are responsible for social care. But the municipalities also have some responsibilities regarding healthcare. They are responsible for primary care provided in special housing. That's by law. And in 20 of 21 regions, all regions except for Stockholm, the municipalities are, even by agreement with the region, responsible for primary home care provided in regular housing. And this means that both regions and municipalities are responsible for the provision and financing of rehabilitation. The regions are responsible for rehabilitation provided at hospitals, in outpatient clinics, and in primary care centers, while municipalities are responsible for rehabilitation provided through the primary care services that they are responsible for. And individual circumstances and needs determine where the outpatient rehabilitation takes place. Young patients and patients that are of working age and on sick leave are more likely to get rehabilitation in outpatient units, while elderly patients and patients with severely reduced capacity are more likely to get home-based rehabilitation. And because of the decentralized system, there are regional and local differences in policies on what services to provide, but also differences regarding the organization and the financing of the rehabilitation services. There are differences regarding, for example, payment mechanisms, difference regarding patient fees and charges for technical aids, and also differences to what extent the services are provided in-house or by contracted private providers. Next slide, please. At the same time, there is a national legislation that very much influence where rehabilitation takes place and how it's financed. And that's the Act on Collaboration and Discharge from Inpatient Care, which was introduced in 2018. Since the 1970s, many efforts have been made to strengthen the role of primary care in the Swedish healthcare system. And the aim of this new law was to improve coordination and collaboration between regional and municipal healthcare providers and the municipal social services, and to promote discharge from inpatient care as soon as possible after the treating physician has assessed that the patient is ready for discharge from hospital but need further municipal care and support. This law describes in detail which measures must be taken from hospitalization to discharge to prepare the municipality for a takeover. And the municipalities, they had a liability for payment already before 2018. But the new legislation, which has a much stronger focus on collaboration and sharing of information between different providers, This legislation shortened the time for the municipalities to bring the patient home from hospital from 5 to 3 days after the treating physician has not notified relevant bodies that the patient is ready for discharge from hospital. And if a patient ready for discharge is at hospital longer than 3 days, the municipality must pay for the hospital cost. This new legislation on collaboration has had a very big impact on where and how rehabilitation services are provided and financed. Since the municipalities have strong economic incentives to take charge of the care and rehabilitation, it has freed up a large number of hospital beds. Although the total number of hospital beds has also decreased during this time, the percentage of beds occupied by patients ready for discharge has decreased from 7% in 2017 to 4% in 2023. We think this is good from a financial and efficiency point of view, but it's also good for the patients who can avoid unnecessary hospitalization. I stop there. Thank you for listening.
Thank you very much, Erik. And what a nice example. And I'm really curious also to hear more. Maybe there will be questions also about what it means in terms of the quality for the service for the patient. Okay, so now we move to Solomia Kazianchuk. She is the National Professional Officer for Health Financing in the WHO Country Office for Ukraine. And Solomia will take us through the reforms and the financing situation in Ukraine. So, Solomia, over to you.
Thank you, Ewout, and thank you for the opportunity to share some of the lessons learned from Ukraine. As many of you know, and as Jarno mentioned in the introduction, the need for rehabilitation care has continuously been growing over the last couple of years. In 2014, when the conflict started, there was the first upscale need for rehabilitation care, and rehabilitation was just brought onto the national agenda as a priority service. Over the years, as the health financing reform continued, the National Health Service of Ukraine, the national purchaser, was established in 2018, and the National Benefits Package, the Program of Medical Guarantees, was established. Rehabilitation has always been included and has been prioritized. But throughout these years, the place that rehabilitation has had within the scope of the benefits package has continued to grow. As you can see on the slide, the budget specifically for rehabilitation within the benefits package, within the PMG, has grown almost threefold. This has been mostly due to growing needs of rehabilitation due to war, so much trauma, but also, for example, due to non-communicable diseases growing, etc., leading to increased stroke, requiring also additional rehabilitation. Such growth has been clearly also shown in the number of episodes of care, which show the growing need and number of patients who have been benefiting from rehabilitation over the last couple of years. So growing also almost threefold since 2022 to 2024. And this has also been driving the number of providers in the network who are able to provide rehabilitation care in the country. But as the budget has been growing, as the needs have been growing, Ukraine is also undergoing severe fiscal constraints. And even as the budget grows, there are still limitations in terms of what Ukraine can afford to pay, and much more putting pressure on ensuring efficiency and effectiveness of the money that is being spent on rehabilitation. In this scope, the government of Ukraine had reached out to us at WHO to support them with looking at ways of how to ensure the best efficiency of spending on rehabilitation care in Ukraine. And in addition to the report that has been published by the European Observatory, the Ukrainian office, together with the Barcelona office, have done our own report on specifically looking at how rehabilitation has been financed in Ukraine. And I wanted to share a few of the results and findings that I think are quite valuable, not only for Ukraine, but more broadly for various countries. So Two quite important points are prioritization and eligibility is important in terms of fiscal constraints. And second, that financial incentives need to be well designed and monitored. So the first, on the slide, what we see is what are the current diagnoses that we see that are receiving care in inpatient rehabilitation in 2024 in Ukraine. And we see that nerve damage is about 1/4 of the cases. We see about 13% for patients after stroke, but we see almost 14 patients also for non-priority musculoskeletal services such as dorsopathies and arthropathies. And this is extremely important also to note who is benefiting from rehab and what can we see. So what we don't have here is also we have data on age of the patients, but we need to have even more information. In terms of incentives, we also look at complex patients. So we have 4 categories of complexity in Ukraine, and we see that the financial incentives that we have introduced in 2024, they didn't actually change how patients' profiles have changed from 2023 to 2024. So the incentives have not changed. So what this shows to us is that we need to have more information about patients. We need to also understand functional status, not only the diagnosis of the patients, but also functional status to make better decisions about who is receiving care. We need to make better decisions about complexity levels, also taking into consideration functional diagnosis. We need to look at who are the people who are not receiving rehabilitation who could benefit. So not only who is receiving, but who is not. And also about looking at appropriateness of care to make sure that not only services are focused on inpatient care, but also on outpatient care. Additionally, we need to continue reviewing and monitoring all of the data to make sure that all of the changes that we implement, we see, are they actually changing the system or not? And just briefly sharing, you can find more of the findings that we have found in our recently published report on Ukraine that we've published together with the Barcelona office that I think you can find wider reforms and guidance. Thank you.
Thank you very much, Solomia. And I can see there's still so many challenges to grapple with. So I think you have your work cut out for you. You already mentioned the Barcelona office. So let's go to the Barcelona office to Trin Habicht, who's a senior economist there. And she will give us a bit of an international perspective on this. This is a challenge that you see in many countries in the region. So over to you, Trin.
Thank you, Ewout, and hello to everyone. And maybe let me start with why we felt when we started our work in Ukraine that we truly need to learn from other countries. Yes, there is literature also on rehab financing available, but most of it stays at a very general high level. And when you go design related questions, then you understand that you need to do a deeper dive because you really want to understand what are these concrete design choices that other countries have been also facing, and to make the rehab financing to work to help to achieve the goals what the particular health systems have. And also what has been very important, its consideration there is that rehabilitation is somewhat different when we take it's specialized acute care in general. And good example here are payment methods, as it's already Ruth showed you. So for example, it's in acute inpatient care, many countries rely on DRG type of case-based payment. And therefore, our first question was do countries also use DRGs for subacute rehabilitation? If they use DRGs, do they adjust it to work it better for rehabilitation? Or do they actually opt for different payment methods? And I think that's it's really where all the deep dive became real fascinating. For example, Lithuania, yes, is using DRG system also for subacute rehabilitation, but to make it work for the rehabilitation, they do apply like it's quite a sophisticated set of adjustments that are rehabilitation specific. Another like it's if we look like international like it's experiences, kind of very interesting insight was that usually when it comes to bed day payments, in acute care we are rather like it's not encouraging countries to use it, but when it comes to rehabilitation, then what do we see is that actually several countries use bed day payments intentionally. For example, Estonia and even Switzerland. Switzerland has it's a very sophisticated rehabilitation-specific DRG type of system, but as like length of stay is used as an adjustment in the system, it starts to it actually in real life operate more like a bed day payment. And I think when we look it through the lens of rehabilitation, it all makes perfect sense. Rehabilitation is goal-oriented care. Achieving rehabilitation outcomes depends on each individual patient. And if too much financial risk is put to the provider, it may create it like it's incentives that start to work against rehab practice. And really it's a huge thank you for all country experts who allowed us to do that deeper dive. And as already mentioned by Natasha, by Jarno, by others, this work is not really it's beneficial only for Ukraine. There is a lot it's to learn for those countries who want to critically rethink how they are financing rehabilitation. And there I think also it's a very helpful lesson from Ukraine is that it's one thing is to look what other countries are doing, what works, what doesn't work. And another thing, what Ukraine did, let's look it's data available and try to understand what are our performance issues. Then we know how to best use that other countries' experiences to fix performance gaps we have in the system. So that's it. And then back to you, Ewout. Thank you.
Thank you for that, Trin. And I think it calls for all of you to start reading the policy brief. So thank you for that. And thank you for these helpful, putting this in perspective. Now I would like to go to Stephanie, because Stephanie's been very active together with Erica in the chat. Many questions. I couldn't keep track of all of it, but maybe you can distill 3 discussion points that we can use and feedback to our panelists, who I would also want to ask now to switch on their cameras again and join me again online here. So Stephanie, over to you.
Great, thank you, Eva. Yeah, so we've had some very thoughtful questions and comments come in, and they center around 4 main themes, I'd say. So the first is, how can we ensure equitable access and affordability in systems where public rehab is under-resourced and private care is relatively unaffordable? So that's about private versus public and unaffordability. The second is about how countries can better coordinate fragmented rehabilitation financing so that their patients experience a more seamless pathway, whether across public, private, and NGO sectors. So we heard somebody speaking to the case in Nigeria, or across regional and municipality levels. That's where maybe our panelists from Sweden might be able to weigh in. The third question is around what payment models best support new modalities, such as telerehab, and how to ensure that these services maintain quality and continuity as well. And finally, it would be really lovely to hear from our Ukrainian panelist on what practical financing steps Ukraine should prioritize over the next year. Thank you.
Oh, these are enough questions, I think, to get us going. So we have our panelists here. You heard the questions. I'm not going to ask one question specific to you, so perhaps you want to react to some of these. Ruth, could I perhaps start with you? Is that okay?
Sure. Yes, I will answer to some of the questions. So regarding the public and private mix, we know that purchasing services from public and private providers can increase the availability, because then we don't rely only on public providers, but the purchasing and the contracting should be done with caution, because we want the competition to be fair and the prices to be the same, and not to give too much advantage to the private providers, and the public providers would be under more risk. This is one thing. The other is paying for new models of care. the traditional payments like budgets and fee-for-service, they are imperfect and they should be complemented with new models. And there are countries experimenting now value-based payments. So for example, they complement budgets with pay for performance and pay for coordination. So for example, a provider gets a specific payment if he has meetings with other providers, or if he meets with the parents of a child that has multiple morbidities. For example, as I mentioned, a hospital that gets the payment for the full episode of care that includes the outpatient care and the whole episode of a whole year of treatment in the outpatient care. And this kind of forces the providers to work together and coordinate the care and reduce waste, because then they can share the savings. So these are value-based payments that can be implemented for different models of care. And telerehabilitation, good potential, has to be used with caution, for the proper the patients that suit for that. Not any patient can be treated with telerehabilitation, and the payment, there is no one model that fits to any country. It has always to be adapted to the context of the country, the level of resources, the amount of providers, what are the incentives we want to create to increase productivity or to contain the costs or to improve quality. So all this has to be measured, and there is no one single answer. This is the best payment. It depends on the context.
Thank you, Ruth. Yeah, let's go to Melissa. Maybe also again the public-private, but anything you've heard you would like to react to.
Yes, in Sweden we have many different paying mechanisms. Since each region or decide themselves, it looks very different in different regions. It also depends on if it's outpatient care or inpatient care. Sometimes you have one system for paying the outpatient care in your own region, but you had other mechanisms for paying providers in other parts of Sweden. What I think is interesting in Sweden is that we have a lot of private provision of healthcare, at least especially when it comes to outpatient care, but we have not to the same extent private financing of healthcare. If people expect to be able to choose a private provider, even when it comes to rehabilitation, through the public, the tax-funded system. So the legislation says that the regions, when it comes to primary care, they have to treat their own providers and private providers equally. It has to be the same rules for all of them.
Yeah,
and this goes with, and since the primary care centers are also it's multi-professional centers, including physiotherapists, occupational therapists, and other people working with rehabilitation. This includes the rehabilitation as well.
Very nicely echoing also messages from other countries. So thank you. So Lamia, there was one very specific question about next steps in Ukraine, but please feel free also to add your thoughts on any of the other questions that were posed.
Thank you. I wanted to mention 2 points, and one actually links to another question I saw in the chat. But the first, one of the key priorities for next year is introducing the Barthel Index. So one thing, as I noticed, in terms of prioritization of care, it's not enough just to look at the diagnosis, but actually to understand the eligibility for rehab in terms of their functional status. So this year, they've already started introducing an e-health, the Barthel Index. So this is something that will be introduced and rolled out eventually, leading to eligibility changes in the future. So this is one, and this is really important in terms of fiscal constraints and prioritizing patients. The second, there was also another question in the chat, and this is exactly what we're looking at is how to ensure continuity of care. And so ensuring that patients receive rehabilitation after stroke. We see in Ukraine that there is about an unmet need of 80%. So about 80% of those who would be eligible for rehab do not receive it after stroke. And we are recommending to introduce financial incentives to actually promote rehabilitation after stroke. And the question in the chat was, who would you provide the financial incentive to? And the recommendation we have chosen to provide is to actually pay the provider who's providing the stroke care, incentivizing them then to communicate and refer and find a place for that patient to receive rehabilitation. Moving on.
Thank you, Salome. Yeah, actually reflects also what we found in other work about rehabilitation after stroke, that in many European countries, or some European countries, still wasn't covered. So it's definitely something to look into. Okay, shall we then go to Trin?
Yes,
I'm
thank
sure you
you.
have many thoughts on all of these, so please add where you would like, and then I think we still have time for another round of questions if there are any.
Yes, it's. I will comment also this public-private providers issue, because it's also came up like it's in Ukraine, and very much like I agree with Ruth, like it's what already like you said, that it's really like it's treating them like it's a public-private providers like it's on equal terms in terms of the price and payment. So it's kind of balancing incentives. I think what is also important, and not really specifically only to rehab, but overall, like it's opening it's a public funds for private providers. It really needs to be like it's guided by like a policy objectives. It's what do we want to achieve, and they're the real like it's a starting point needs to what our population needs, and if we see that actually needs are unmet, then how we can like it's really benefit from like it's allowing like private providers to come and fill the gap. Because like it's, for example, like if we take a situation also in Ukraine, then if your real constraint is that you do not have a limited health workforce, then like it's opening the market, like it's for like the more like it's a providers and also for private sector. It means that actually there is a competition, like it's not for improved quality, but rather like it's a very limited, like it's a human resources who are currently available. And that might put in risk, like it's really that it's a health workforce is moving to like it's a rather like it's a less complex, treating less complex patients, and in the public sector you face like it's a shortage. So that's like it's just like one additional comment and consideration. And then of course I think what is fascinating, like it's also like it's worrisome, like it's a kind of, if we think about private providers, then not all private providers are the same. So there are non-profit, there are for-profit private providers, and there are differences in ownership. And we know like it's a kind of increasing concerns, and some countries are struggling with private equity ownership, like it's modalities, and we definitely need to keep have to keep eye on rehabilitation, because it is kind of one area what is quite attractive also for private investors. Thank you. Back to you.
Stephanie, back to you. Is there maybe one, maybe two questions?
Yeah.
We have maybe a few minutes left, 5 minutes for one round. So
sure. Yeah, so one just came up actually, which is really interesting, and touches on something we've talked a little bit about, which is the fragmented financing. And so the question is, how can countries better engage social protection, disability, employment, and other sectors in rehab financing, especially when there are competing interests and fragmented funding streams for these high risk and vulnerable groups? And the second question, maybe just to like wrap it all up, is looking to the future. As rehab becomes an increasingly important area of healthcare, what should all countries be prioritizing in their financing reforms?
Okay, so can we do a really quick round with the panelists? Maybe like 30-second answers. Ruth, you start again. And let's see where we get. It's a lot to cover, but I'm sure you can do it.
Yes. So as I mentioned, there are a lot of other sectors that jump in the rehabilitation care, and they sometimes cover different populations, or they provide extra coverage. For example, veterans of war or social security, social care for the disabled, long-term care for frail elderly, and so on. These systems have to be coordinated, otherwise there is waste, there is people falling between the cracks. That's the function of the care coordinator. The care coordinator can help the patient navigate the system and cross the different sectors and not get lost and get all the services they need. Prioritizing for the future. I saw many of the comments from countries that cannot invest more money in rehabilitation, and that's obvious. I think that the key is to prioritize coverage, those most in need, those most vulnerable, eligibility criteria to identify the people who really need more care, health technology assessment to cover the most cost-effective treatments and not any treatment, and balance the payment mechanisms, and let maybe the people copayments based on income. So let those that have higher incomes pay higher copayments, and those with lower incomes pay lower copayments or no copayments, and somehow use the money that is available in a better or more efficient way. Over.
That's a bit more than 30 seconds, Ruth, but you'll have the final word as well, but then we'll give you maybe less time. Well, we go in the same order. Eric, you want to come in on any of these two?
Yes, it's definitely absolutely right that that's important that the healthcare sector can cooperate with other sectors. And that's why we have the legislation I talked about is very much about cooperation between the healthcare sector and the social services. And that's why some years ago, the responsibility for some primary care was transferred to the municipalities to coordinate and get better cooperation between the social services, social care, and the primary care services.
Thank you. Okay, so let's go to Solomia, if you want to come in. For final thoughts on your side.
You. It's hard to follow Ruth. I think she covered it very comprehensively, but this is definitely a challenge we see also in Ukraine. So for example, prosthesis, assistive technologies, those are covered by the Ministry of Social Policy. There are a number of different actors, so Ministry of Veterans, Ministry of Defense, every ministry has their own priorities, etc. And this is really a balancing act to bring everybody to the table, to speak together, to prioritize, to link where finances can be used more effectively. This is something that I would say we don't always manage, but this is extremely important. So exactly, patients don't fall through the cracks, because this is often where we see some services not being clearly, whether then they're funded, by who they're funded, etc.
Thank you. Trin, your final thoughts.
Yes,
final thoughts.
And yes. And then maybe it not only focusing on financing and how financing can fix, and regarding the fragmentation across different systems. So I think what also is important is how we collect and share data. And then I think it's not only from the rehab perspective. I think it's kind of overall should be a principle of whatever public services are there. So it's a kind of data is collected according to following the same principles, and then also data it's possible to put the data together from the person perspective. I think that would already it's a change a lot. And then we all seek ways how AI can to bring benefits. That is definitely one of the areas where a lot of good can be done, using AI as well. So thank you.
Thank you very much, Trin. And now over to you, Ruth, for the very final short wrap-up of the whole session, which is not an easy one to wrap up, I'm afraid, but you have 30 seconds, so good luck.
Okay, so maybe I will just thank everybody that contributed with data. And it's super interesting to compare countries and learn the different strategies that countries are using. It's super valuable to this mutual learning. I think the work the observatory is doing is nice because allows us to have this creative policy options from different countries. And for the details, just please go to the report and you can get in touch with us by email.
Thank you. Yeah, thank you very, very much, Ruth. Also, thank you very much to all the panelists for sharing their insights. Also, thank you, our watchers today, and for their very active participation in the chat. I would like to also thank Dimitro, who was doing the translations. Must not have been easy. And I hope that you check out our website and look for other webinars that we're organizing, and hope to see you there and then. So goodbye, and hope you have a great rest of the day. Bye.